Back after the PAS, which was a wonderful opportunity for teaching and learning again about neonatal issues. Today we have another webinar, and I've invited Samuel Gentle. He is an associate professor and neonatologist from the Department of Pediatrics at the Yale School of Medicine. And he's been interested, and his research has been on BPD, and particularly the BPD we reach at the end of the NICU phase, and then the more severe cases, which then develop pulmonary hypertension, which significantly contribute to morbidity and mortality. So today, welcome, Samuel, and over to you.
Awesome. Thanks so much. Really appreciate the invitation. I hope what I prepared today is a fairly cohesive talk. I try to weave it into like a cohesive narrative, but apologies if it feels like a lot. But I'll try. I hope I didn't pack in too much. And I don't have anything in particular to disclose. I am supported by the NIH through a K23 award. And I will be talking a little bit about some unapproved or off-label things, and as none of the therapies for BPD-associated pulmonary hypertension are FDA approved. And in terms of the agenda today, I think it's always kind of tricky to think about the entry point for this disease. So I've kind of considered a few different angles, but the first of those angles will be BPD pulmonary hypertension in context to historical origins of both BPD as well as adult PAH. I'll then shift to means by which we can identify disease, more specifically our current paradigm of how we look for this specific disease, some other what I'm calling biomarkers at the bedside, some signals from the monitor that can kind of give clinicians and providers a clue as to whether infants are actively developing PH. I'll touch a little bit on potentially modifiable exposures during the NICU stay. I'll set the stage for disease trajectory, as many of these infants will have severe trajectories, but another half of them will have either resolution or will survive to discharge. But how can we sort of figure out which infant will be the more severe trajectory as compared to the less severe trajectory? And then what I would consider, with all of this in mind, what the path forward may look like. So breaking off the first piece of historical origins, and what will soon be displayed on the screen will just be kind of various landmark events in preterm respiratory care dating back to the first definition of Dr. Northway in 1967, the first trial of antenatal steroids, trial of surfactant. These are many trials to be illustrated on this slide, and then the first kind of consensus-based definition decades later in 2001, the CAP trial, the large randomized trials for oxygen saturation targeting as well as inhaled nitric oxide. And then this new iteration of the definition from the NICHD now over 5 years ago. And if you were to juxtapose what's been understood or published in the literature about pulmonary hypertension, it's a much shorter timeline, with the first prospective cohort study coming out of UAB, where I recently left prior to my to joining the group here at Yale, was in 2010. And the first kind of guidelines around management for this disease were in 2015, so just 10 years ago, from American Heart Association in conjunction with American Thoracic Society. And if you were, so it's a fairly new disease in terms of what we understand, in terms of the longitudinal history of preterm lung disease, and it's also very young in comparison to what's known in adult PAH, as there have been a myriad of different PH-related pathways that have informed large seminal randomized trials, building this robust group of evidence for how we can manage and treat adults. But that type of rigorous data certainly does not exist for our infants. And the second angle or entry point for this disease that I think is important to mention is relating this specific phenotype to the other phenotypes of BPD. So BPD being this, illustrated an umbrella here. It's an umbrella term, and beneath that umbrella, there's a lot of different, I think, evolving schemas for how we can better classify BPD, but these are a handful of what's been published in the literature, parenchymal type, vascular type, and so on. The means by which we identify these specific phenotypes being from these various diagnostic tools. But I think what's most important is the management will be fundamentally different if we are able to identify a specific phenotype for a specific infant, although the most common phenotype being a sort of a mixed a potpourri of a few of these different types. But you may treat one infant successfully with a bronchodilator, whereas another infant may be more successfully treated with a pulmonary vasodilator, for instance. And then the final entry point that I'd like to use for this disease is the backdrop of literature that does exist for BPD, speaking more broadly, not specific to phenotypes, but just what has been trialed in these most vulnerable infants. So, a lot of different therapies, very large randomized trials with various effect sizes, some of these not even beneficial. But when we think about whether these therapies work or don't work, which phenotype do those therapies work for? And as none of these phenotypes have been robustly reported in these trials, do any of these therapies impact this vascular phenotype or BPD-associated pulmonary hypertension? So why do I care about this specific phenotype? Why have I transitioned to dedicating my career to this specific phenotype, and I likely plan on carrying that forward for the entirety of my career? Well, it's not uncommon. So around 20% of extremely preterm infants develop this disease. So that is, for instance, double the NEC rate at my prior institution, and it's it's potentially lethal in infants. So this is survival up to age 2, and this the mortality rate in BPD pulmonary hypertension, for instance, is higher than what has been reported for NEC. And I'm just using NEC as an example because I think of that as a pretty serious morbidity linked oftentimes to mortality, whereas this disease is, I would say, arguably more common and potentially more lethal. And despite it being such a severe and not uncommon illness, there is this is a recent guideline that was published just a handful of weeks ago. So this is sort of an updated ATS practical guideline. But one of the consensus takeaways was there's a striking lack of empirical evidence regarding management of those whose disease has progressed despite optimal pharmacotherapy. And I would say there's lack of evidence for any management of infants, whether that be pharmacotherapy or otherwise. So there's just it's a severe disease for which there's very little data to support management. The sort of embryological and postnatal history of this disease has been sort of compartmentalized into these various pieces of their trajectory. And I think there's a lot of investigators focusing in on specific time points. And illustrated at the top of the slide here is, embryologic gestation, and then at some point these preterm infants are born, and then disease will develop, and this will be a little bit more clear here in a second. But in terms of the genetic predisposition, there are folks that have invested their careers in the sort of genetic implications, Jen Trippman being a pioneer in this field, who's looked at single nucleotide polymorphisms that caused a decreased endogenous NO production for these infants to develop pulmonary hypertension. Others have focused on these kind of fetal programming time period, like Dr. Humble and Adman. Dr. Adman has been involved with, I would say, far more than just that silo of this trajectory. And then the pre-disease up into echodiagnosis state. So folks like Sana Arjans and Pete Morani, who's also collaborated with Dr. Eidman, who have focused on these other sort of mechanisms leading up to the disease. And then I think what's also critical is these babies go home, they grow up to be children, young adults, adolescents, et cetera. And folks like Kara Goss and Mary Mullen have really focused on these infants with pulmonary hypertension. How do they do later on? And this is certainly a disease that doesn't always go away, and it can last into adolescence and early adulthood. But the piece that I've really focused my career up until this point on is the sort of pre-disease up to diagnosis time point. So identification of disease, as well as our current paradigm of screening. So which infants are at higher risk? I've already kind of mentioned the population of interest being extremely preterm infants, but within that population, who's more at risk? And there have been a number of epidemiologic studies looking at what are some risk factors, but these risk factors will not be, certainly not unique to this phenotype. So birth weight, gestational age, PDA, NAC, these are all either demographic features or comorbidities that have been associated with BPD, speaking more generally. But can we utilize some of these risk factors to not just predict BPD, but this specific BPD-PH phenotype? If we're able to do so, we may be able to identify these at-risk infants for this, again, very severe disease early on. And moreover, we may be able to identify which patients would be an eligible patient population in which we could conduct randomized trials specific for this pulmonary hypertension phenotype. And there have been a number of studies that looked at risk for PH by BPD severity, with the takeaway being with successive BPD severity, there's a higher likelihood of developing or having an association with pulmonary hypertension. So if you look at, and this is a recent cohort study that's under review, but if you look at using the 2001 NICHD definition, if you look at babies with severe BPD, around 40% of those will develop pulmonary hypertension during the hospitalization. You can see some other outcomes like PH-associated mortality being around 9%, and the likelihood of BPD or death, 43%. But what hasn't been reported robustly in the literature is how this new evidence-based definition and BPD severity within this definition is associated with pulmonary hypertension. And so you can see that actually around 60% of infants with grade 3 are at risk for pulmonary hypertension during hospitalization. And if you look at the composite of pulmonary hypertension with death, that number is 70%. That's a striking number. Infants with grade 3, 70% will either develop pulmonary hypertension or death. Thankfully, grade 3 is a less common BPD severity level, but those infants are certainly at the highest risk for this disease. And given that BPD severity seems highly associated with pulmonary hypertension, with increasing severity, increased probability of pulmonary hypertension. And we've recently been performing some models that have tried to leverage currently existing BPD risk estimators, more specifically the one from the NICHD. And I would guess that this audience is familiar with this estimator, but I just have some screenshots from it's online, obviously readily available, and I think incredibly useful. And you just enter in these various covariates at these different postnatal time points. This is the 2011 one that uses the 2001 consensus definition. This one uses the Jensen definition. And just as an example, so let's say you had an infant that was 25 weeks, so on and so forth. You then come up with the risk for these various outcomes that sum to 100%. And so let's say for this specific infant, the risk for moderate to severe BPD or death was 84%. Well, what if you took that risk estimate across a population of infants and used that risk estimate as a predictor for pulmonary hypertension? Again, because BPD severity seems to be fairly intrinsically linked to pulmonary hypertension. So with more severe BPD, more likely to have PH, and that's the study that we performed. But before I get into the regression models, I'll just give you a little bit bigger sense of this cohort. Again, this kind of represents the covariates that are that go into these regression models from the risk estimation models. And this is a fairly large cohort, all out of UAB, around 800 babies. And you can see that already there's some pretty striking demographic differences with infants with pulmonary hypertension being born at a lower birth weight and a lower gestational age. There are some race ethnicity differences. Infants, this is on day one, the first day of after birth. 89% were invasively ventilated, so there's already respiratory differences, likely informed by these being smaller and more premature babies, and a difference in FiO2. So if you were to use these covariates, plug them into the risk estimation models, and rather than estimating the risk for BPD severity, you're estimating the risk for pH. The performance for the composite of moderate severe BPD or death has an AUC of 0.81, so pretty strong performance. And similarly, if you use the 2022 risk estimator, you can you approximate the same AUC. And so if you sort of plot these high-performing models on the same curve here, in addition to our own internal model that obviously has different weights for the risk multipliers for the regression model, within this internal model, at least it outperforms these other two as well, but all of which have fairly high AUCs. So this is a readily available tool that may be employed to predict risk for pulmonary hypertension. So I've sort of discussed the risk for pulmonary hypertension by BPD severity, but how do we look for this disease? What's the current state of how we screen for pulmonary hypertension in the NICU? Well, there's certainly pretty limited evidence to suggest an optimal strategy, but current recommendations are to suggest that screening echocardiogram in infants with established BPD. There are a number of different entities that have sort of published their recommendation with sort of a singular screening echo, either in all infants with BPD, or some have been more specific about infants only on positive pressure ventilation at 36 weeks with a singular screening echo. That's the kind of current state of the recommendation. But I think what is challenging about that recommendation is that the timing at which infants develop echocardiographic evidence of pulmonary hypertension is pretty variable, and 36 weeks is a pretty arbitrary time point. So let's say, and this is, again, UAB data, this is adapted from a publication a couple of years ago, and you can see that if you were to only screen maybe up to and including 36 weeks, and this is characterizing a new diagnosis of pulmonary hypertension, and UAB has a pretty robust screening program in which there's a screening echo at 1 month of age, and then every month successively until discharge. So some infants have 6, 8 echocardiograms, and that'll become a little bit more relevant later in the talk. But that's how we can kind of better classify the exact, or not exact, but closely approximate the postmenstrual age at which these infants develop pulmonary hypertension. And so you can see a lot of infants develop it later than 36 weeks. You can also see that the trajectory of pulmonary hypertension, so there's a number of infants that have resolution largely later after a disease has been established, but the majority of infants with established pulmonary hypertension persists until discharge, as you can see here. And so what we wanted to do is, given that we have this large data set of echocardiograms, again, we have a fairly, what I can say, a comprehensive screening program. We can take pieces of this echo data and see what it would look like if a center were to only get echoes at certain postnatal time points. How informative would these different screening strategies be to sort of develop potential evidence to inform this approach? And so, as I mentioned, we screen monthly, but throughout the hospitalization, but we hypothesized that serial echocardiography throughout hospitalization would improve pH detection with an increase in positive predictive value with postnatal age. And so this was a cohort of infants born less than 29 weeks, and I already mentioned our kind of screening approach, but there's sort of 4 screening approaches that we sort of thought about that might be employed in a hospital would be a comprehensive screening approach like the one I mentioned and the one used at UAB, potentially an early screening approach. Maybe if we identify these babies early, we can intervene early, maybe attenuate outcomes. And so an early approach being you get an echo at 1 month of age up to and including 36 weeks. Singular screening, like I mentioned, which is the current recommendation of 1 echo at 36 weeks, or late screening. So starting at 36 weeks and then getting monthly until discharge. And so if you look at comprehensive screening within this data set, there are 136 babies with a BPD-PH diagnosis. If you looked at only babies with grade 2 to 3 BPD, you can see that you don't catch them all. Again, I had mentioned that babies with these higher grades of BPD are more likely to have BPD or pulmonary hypertension, but it's certainly not, I would say, sufficient as a screening approach. You can see the postmenstrual age at diagnosis, the proportion or the number of infants that went on to have mortality. If you're getting that many echoes, it's possible that you have a single positive echo or sort of a false positive. So I did also want to report that. And then also in terms of cost effectiveness, as I have talked to some centers to convince your cardiologist to get 7 echoes on a baby, how many negative echoes does it take to get to that positive screen? And if you have a comprehensive approach, it's around 2 negatives before you get that 1 positive. So what about an early screening approach? You catch only 78 of that 136, and I'll kind of show you just the other screening approaches and how many of these infants you catch. So you catch about 57% of cases with early screening, 43% with singular screening. So the current recommendation, you miss over half of infants. But I would say what's probably the most cost-effective that catches the majority of infants, and I think if you remove these single positive or sort of false positive babies, you really catch the vast majority of these infants is the sort of late screening approach. So getting an echo at 36 weeks and then every month thereafter. The number of negative echoes prior to echocardiogram, the positive echo is about 1 also, so it's a little bit more cost-effective that way. If you want to see it through the lens of traditional performance approaches, you can see that there's some sensitivity gain after 36 weeks postmenstrual age, and this is the same data by postnatal day, and as well as negative predictive value gains after 36 weeks as well. So just sort of distilling some of the information from this chunk of the talk, the 2019 evidence-based definition may have improved performance in identifying the infants at most risk for pulmonary hypertension. The currently available risk estimation models are fairly high-performing when it comes to predicting risk for pulmonary hypertension when you use specific composites of that estimator. I'll say that the current recommendations for a singular echo may be insufficient in catching infants with pulmonary hypertension. But I think what remains unclear is if you can identify babies earlier, can you really attenuate infants' long-term outcomes? I mentioned that already. But I think what another huge takeaway is, rather than getting 7 echoes in these children, are there any other parallel biomarkers, foreshadowing for the next section, I believe, that we can use in parallel to just sort of our BPD risk or BPD severity? There's certainly more that we can use to sort of inform whether this infant should get an echo with a higher frequency than another infant potentially. And with that, I will kind of move to this next section, which is a kind of a growing passion of mine, and that's using biomedical signals, or essentially just vital signs off monitors, as a biomarker at the bedside. And sort of as a prologue to that, we all are probably fairly familiar with the NEOPROM studies, looking at these various oxygen saturation targets in infants that have randomized nearly 5,000 infants across the world, many of those in Australia. And Obviously, these trials reported the outcome of death or BPD, but what remains a huge knowledge gap, I would say, is how SAT targeting influences risk for pulmonary hypertension. I won't keep sort of repeating this echo screening approach at UAB, but this will just sort of visually depict it here quickly. So, again, we get our first echo day 28. It'll have the serial echoes indicated by these downward arrows up until discharge. And for this study, it was an observational study looking at oxygen saturation achievement at the time of a positive screen. And so this positive screen indicated by this red arrow, these were identified as cases. The way we identified pulmonary hypertension is with the following definitions, which I won't read. These achieved saturations were then compared to babies with BPD, but without pulmonary hypertension. Those were the comparisons or the controls, and they were matched by gestational age at birth and then by postnatal age also, at which the echoes were performed to show that that baby with BPD did not have pulmonary hypertension. And then we characterized oxygen saturations in that week leading up to that diagnostic echo. And so this is going to show achieved saturations by pH status. And the y-axis is duration of oxygen saturation achievement. You can see the different oxygen saturation distributions on the x-axis. And in red is illustrated those babies with BPD without pulmonary hypertension, and in blue, those with pulmonary hypertension. It's a little bit hard to make out differences in this leftward panel, but if you look at the rightward panel, you can see that infants with pulmonary hypertension very rarely, or less commonly, I'll say, achieve these higher saturations above 95. But I think the way that that could be even better illustrated is in this sort of graphic tracing. And it's maybe a little bit subtle at first, but let's start with this baby with no pulmonary hypertension. You can see that the SATs, this is a pretty tight time, but no, this is time in seconds on the x-axis. So this is extremely granular data, but you can see that it continuously touches 100%. As you can see here, comparatively, this baby with pulmonary hypertension spends far less time touching these higher saturations. In terms of mechanistically, or how this sort of, what's the physiologic plausibility of why this may be happening, I hypothesize that there's probably some degree of intracardiac shunting that precludes an infant from achieving these high saturations. And if you were to sort of visually depict this on a histogram, again, this baby with BPD, no pulmonary hypertension, is able to achieve these high saturations comparative to this baby with pulmonary hypertension that has this more sort of bell-shaped leftward curve. Well, you may say, okay, well, maybe the babies with BPD are exposed to higher oxygen comparatively, but it's actually the opposite. So the babies with pulmonary hypertension are on higher oxygen and achieving lower saturations. And you can see that borne out in this sort of snapshot here, and then sort of longitudinally up into the diagnostic echo over time. Well, what about in babies with established disease? Do they have different distributions of oxygen saturations? And it's less of an effect comparative to the BPD versus PH babies, which you can see the distributions here. And the blue is the survivors, and the red are the non-survivors. But what is interesting is that the FiO2 distribution, as you may hypothesize, is higher FiO2 in the non-survivors compared to the survivors. And so if I were to sort of distill this chunk into a singular slide, infants with BPD alone are on a lower FiO2, achieving higher saturations compared to infants with pulmonary hypertension that are on higher FiO2, achieving leftward saturations, with the implications being that maybe the ratio of oxygen saturations to FiO2, that ratio could be used as a non-invasive predictor. And moreover, given the residual knowledge gap from the SAT targeting trials, could oxygen saturation targeting potentially attenuate pH risk? In infants with established disease, a similar trend in terms of FiO2 and SAT achievement, with some implications being, again, sort of the ratio being used to predict pH trajectory. And again, can sat targeting be something that can reduce echocardiographic metrics of pulmonary hypertension? And in terms of this ratio of oxygen saturation to FiO2, we did look at this in terms of an oxygen saturation index. So it's similar to an OI, but the equation up here, meter pressure times FiO2 times 100, whereas the denominator rather than the PaO2, it's an SpO2, so you can monitor it continuously. And so we mapped this out over the course of a hospitalization to see if there was a kind of a time point of separation in which you could maybe use an oxygen saturation index as sort of an ongoing continuous measure to potentially say that, hey, I think this baby is potentially at risk for hypertension. They deserve a screening echo, for instance. And so you can see that at this time point of 36 weeks, there is some separation in which the baby with pulmonary hypertension has a higher OSI comparative to a baby with BPD that's likely having some degree of maybe FiO2 convalescence, achieving high saturations, thereby driving down the OSI number. So it's if you want to take something from the talk, that might be a helpful one, maybe. And so with the other piece from that kind of distillation slide is whether sat targeting itself can be something that can do not necessarily prevent disease, but attenuate trajectories and establish disease. And so we're proposing this randomized crossover trial in which babies with established disease and mature retinas can be exposed to these different saturation targets. And in the background, we'll be doing cardiorespiratory monitoring, biomedical signal analysis, using a lot of different algorithms to look at hypoxemia lability, et cetera, heart rate variability, looking at echocardiographic metrics after these different set target exposures, and so on. But this will be very much a pilot study of around 40 babies that we're about to start enrollment. What about intermittent hypoxemia? So we were just discussing oxygen saturation achievements. What are they achieving? But what about the dips in oxygen saturations? That's a similar but different kind of question. So intermittent hypoxemia commonly occurs in premature infants. We're all very aware of that, how volatile or dynamic and variable these babies are. And the frequency and duration of IH has been associated with BPD more broadly. And there's certainly a lot of observational data looking and linking intermittent hypoxemia to other forms of pulmonary hypertension, sleep apnea, et cetera, COPD. But can characteristics of IH be used to identify infants with pH specifically? And this was borne out as sort of a bedside observation that myself and some of the other folks in our unit have been observing in our infants with more severe pH phenotypes. But just to draw your attention to this, the graphic tracing of the SpO2. And you can see this sort of this wide sort of V-shaped, like kind of fairly symmetrical desaturation event. So a very prolonged, this is probably a baby who alarmed, the nurse came to intervene, cranked FiO2 to 100%, and the kid just continued to desaturate, likely because, again, intracardiac shunting, and obviously FiO2 cannot modify hypoxemia in the event that it's pH mediated. So again, this sort of long, wide event. But there's a lot of ways that you can think about intermittent hypoxemia. You can think about, and this is just sort of an illustrative exercise here with the ribbon on top being babies with BPD and on the bottom with pulmonary hypertension. You can look at the frequency of the event. So how often are they having a hypoxemic event? Compare it between groups. Maybe you look at the duration of the events, and this was sort of our hypothesis at the beginning based on a sort of bedside observation. Maybe those babies with pH have longer events, so it's not just this kind of down and up, quick resolution type hypoxemic event, but a more prolonged, exaggerated IH event. Or maybe you could look at the cumulative duration. So maybe babies with pulmonary hypertension are just spending far less time below 80%, or other severity strata less than 70%, et cetera. Same sort of layout as before, but rather than looking at achieved SpO2, we're now characterizing IH with those sort of three different buckets of frequency, burden, and severity. I won't belabor much of this other than we did perform logistic regression modeling that was inclusive of both demographic and clinical characteristics along with IHK characteristics. And this was a matched data set. So there were 40 babies that were matched for gestational age at birth, but they did differ still with residual differences in birth weight, largely because there were more babies that were small for gestational age in the infants with pulmonary hypertension. But you can see that if you look at established disease, again, only 40 babies, but there were not any differences in terms of these different demographic characteristics and mortality. If you look at some clinical characteristics, again, there's various things that pop out. PDA, I'll get into a lot more detail a little bit later. But again, there's not a lot of separation between infants that died and that survived. And when you look at these, again, different sort of buckets of intermittent hypoxemia, cumulative duration, the frequency, the duration, you can see that the cumulative duration, again, these kind of various strata, so less than 8% was our sort of primary outcome for this kind of specific measure, did not differ, nor did the frequency. But if you look at the duration itself, the duration of the event, and if you look at duration by, again, these sort of severity strata, you can see some of the separation. If you look at mortality being a median of 4 months between diagnosis and death in these 13 babies that died, you again see some separation, largely only in the duration of the event. Again, this is something I think that you could potentially take to bedside. If you were to look at all this data, an infant that has an event that lasts for 20 seconds in duration is twice as likely to have pulmonary hypertension. So that's, I think, again, something that could be sort of readily clinically employed. But if you do adjust for these other known variables that differ between infants with and without pulmonary hypertension, there's no longer significance for these events, whereas birth weight and PDA still sustained through regression adjustment. However, with the analysis for survival, you can still see that these events can be helpful in separating those with severe disease that die from those that are survivors. Just do a quick time check. Okay, doing great. Okay, so I've hopefully convinced you this is an important disease, a severe disease, one that you may get some clues at bedside as to infants that are actively developing this disease, but is there anything that we can do to modify risk for disease? And again, this is all going to be observational data, similar to what I've already discussed. So these are, again, there's a question mark on modifiable mediators here, but the main two things that I'll dive into are PDA exposure, not as a binary outcome only, but as the sort of the duration of that exposure, as well as the ventilator as a, not a, certainly a lot of these babies are exposed to the ventilator, but how long, and is that length of exposure increased risk? So first, breaking off the PDA piece. So the presence and hemodynamic significance of a PDA has been associated with BPD. Very controversial, entering into controversial waters here, but come with me, please. But there's limited evidence for whether the presence and persistence is associated, again, with this pH phenotype of BPD. It seems as though there's more and more evidence supporting expectant management. So I would anticipate, and then the paradigm in which we're entering into, there will be more infants exposed to longer and longer durations of a PDA. So I think this is an important thing to dig into, given the potentiality for more and more infants to have this longer and longer ductal exposure. And so we hypothesized that the presence and duration of a PDA would be associated with pH. And so if you do look at it as a binary exposure, yes or no, you can see that there's already separation, and there's already, I guess, some foreshadowing before in some of the regression models that PDA was, again, standing the test of adjustment. And you can see that here. So, PDA and hemodynamically significant PDA, the risk for PH at that first diagnostic echo, screening echo, either subsequent PH development, so on and so forth. You see a lot of significance here. And this is breaking it out into different durations. So looking at 4 to 7 weeks, 8 to 11 weeks, or greater than or equal to 12 weeks. And you can see development of pulmonary hypertension with each kind of successive month of exposure going up and up in risk. Again, if you look at this into a regression model, PDA moderate to or hemodynamically significant PDA, they stand the test of adjustment. And then, as you can see with the specific durations, these very long exposures. I don't know how many units are allowing their infants to be exposed to 12 weeks of a duct, but you can certainly see that being fairly significant, albeit with pretty wide confidence intervals, as you can see here. And this is just the composite with death here, with this kind of a similar takeaway. And I think this is a nice visual as well. This is a probit analysis. So with each successive addition of a month, what's the probability of death or BPD-PH? Again, trying to come up with a potential time beyond which you would not want to further expose an infant's pulmonary vasculature to a duct. You can see that kind of cross the upper confidence interval crossing 50% around, between the first and second month. Again, I don't have like a specific cut point. This is obviously observational data, and this is looking at the same information through the lens of a hemodynamically significant duct here with the kind of similar findings. Our infants are exposed to a number of different injurious exposures. Certainly the duct is not the only one. So we also wanted to see if there was some additional risk modification of ventilator exposure on top of ductal exposure, thinking that this kind of dual hit of an epithelial and endothelial injury may further kind of compound or synergistically work against pulmonary vascular development. And so this first slide is just sort of a sort of general visualization of the data, the way the data is distributed. So infants with pulmonary hypertension are depicted in blue, and the size of the bubble reflects the gestational age category. And so on the x-axis is days of ventilate, how long were they exposed to the vent, and then on the y-axis, how many weeks of the duct. And so we kind of expected a distribution of over here for most of the PH babies, but you can see that there's a number of infants with very little ventilator exposure, but longer ductal exposure with PH, and then the converse also being true with little ductal exposure, but prolonged ventilator exposure having PH. But I think if you maybe a better framework to look at this, maybe I think it's on the next slide, but this is a PCA plot just to see if these exposures are differentially informing risk for PH. You can see that birth weight, gestational age linked fairly closely together, but ventilator days and PDA days, they're uniquely contributing to PH risk. And then in terms of this slide, I think this is just sort of one final way to think about this. And let's focus on the left part of this figure first. So let's think about the baby that's intubated for less than a month. So that's a baby, that convalesces within that first month from invasive to non-invasive support. And there's I think of this kind of baby a lot. The baby that's off a vent, they're on CPAP, they still have a duct, right? And they're at a month age and they still have a duct and they're 2 months old. And I'm convincing myself that this kid's on non-invasive support. I shouldn't care about this duct, right? But this is interesting data to me in that babies with less ventilator exposure but long ductal exposure are at high risk for pulmonary hypertension. Again, sort of thinking back to the previous slide, and then you see this sort of synergistic effect when babies are exposed to longer durations of both ductal exposure and ventilator exposure, a large proportion of those developing pulmonary hypertension. And and sort of putting a lot of this data together, and I think we've already started to think about subphenotypes of PPHN. So there's many reasons for why we have PPHN in that new term, full-term baby. They have abnormal transitions. Some of these infants will have had PPROM, or they could have renal malformations, or CDH, reasons for which they have pulmonary hypoplasia. They could have meconium aspiration syndrome, so that's more of a parenchymal phenotype. Pulmonary vein stenosis being sort of a post-capillary iteration of this. And I think we need to similarly think and unpack BPD pulmonary hypertension in this same schema, thinking about why a baby developed pulmonary hypertension. Are there subphenotypes, and are the risks of subphenotypes different? Do they respond to therapies differently? There's some babies that maybe have a flow-induced pulmonary hypertension versus a ventilator-induced. There's certainly some that will have crossover with these various exposures. All right, 10:45. All right, I'll try to zip through this last piece just to leave time for questions. This is a fairly recent analysis that's kind of still undergoing iterations, but I'll kind of give you the current model for how we're trying to predict which of these babies with pulmonary hypertension are at higher risk for adverse outcomes. I've talked about some of the IH data and how we can sometimes get a sense of this baby likely being a more severe phenotype versus another baby. But this, we really wanted to focus on the echocardiographic characteristics. Are there specific characteristics in conjunction with what we've been doing all along this afternoon of clinical demographic features that can predict PH persistence at discharge as well as mortality? The other novel piece being, rather than regression modeling, here we're entering into the world of machine learning, which did not perform. So please don't ask me any specific questions about that. But this was, again, observational data, UAB. I've mentioned the outcomes of interest and the different pieces that entered into these machine learning models. I've kind of gone into a lot of this data already in terms of, what characteristics are associated with mortality. So I'll kind of just skip ahead to this slide here, because I haven't really talked about echocardiographic characteristics. So there's a lot of reasons for why an infant is diagnosed with pulmonary hypertension. Many won't have a TR jet, but that is present in some of these infants. Some will have a velocity that we can calculate. Interventricular septal flattening is a sort of a binary yes/no, is sometimes reported. Eccentricity index, or the relationship between the LV and RV, is something that I don't think is always systematically reported in echocardiograms. It's something that we actually, for this analysis, had one person go back through all the echoes and calculate the eccentricity index, and then so on and so forth. So there's some things that are a continuous measure that could be helpful. Some are binary yes/nos, and you can see that eccentricity index kind of stuck out as a pretty interesting covariate for the prediction of mortality, which I think is interesting, largely because it's not commonly reported. So I think this data supports the need for systematic reporting of something along those lines, as interventricular septal flattening is likely a much more subjective way to characterize that. And if you look at the machine learning models and their performance, you can see that AUCs have a lot of variability with some of these outcomes better predicted than others, but and the performance of the machine learning models using, again, echocardiographic, clinical, and demographic characteristics, it never really eclipsed 0.7. So I think there's still a lot of room for a larger data set, more covariates, maybe introduction of other biomedical signals, which is going to be another big centerpiece of my K as it moves forward. And I will leave you with some of what I consider the path forward from what I've discussed with you today. So this, to me, was a pretty powerful publication in terms of how I am now starting to think about this disease and modeling the trajectory of this disease. So this was an analysis in adults with sepsis. It was 12,000 patients for a training cohort that was validated another 8,000 patients. And it was, again, leveraging biomedical signals in a way that I'm hoping to leverage in babies with pre-diagnosis and at the time of diagnosis of pulmonary hypertension. And so you can see these different vital signs. So temperature, so this was a more febrile patient with a higher heart rate, higher respiratory rate, lower blood pressure, both systolic and diastolic. So you may think of sort of this orange and maybe the blue patient is a more severe kind of sepsis patient. And then they looked at mortality by these clusters. So patients with these yellow and blue categories were at a higher odds ratio, both in the training and validation cohorts. So you're using these vital signs at the time of diagnosis to predict mortality in a similar way in which I'm trying to do within the population of pulmonary hypertension. But even more interesting to me is heterogeneous treatment response by cluster. So if you have a patient that falls under this specific cluster, balanced crystalloids may be a preferred treatment as compared to the introduction or utilization of saline. So we can not only predict patient trajectory, but we can potentially choose the right treatment based on that patient's subphenotype, which is something that I'm hopeful. I mean, I'll be using a far smaller data set, but I'm hopeful we can operationalize some of these same kind of concepts. And so what I'd like to do for the kind of path forward is enhance diagnostic screening through early pH detection, enhanced echo diagnostics through a lot of potentially more sensitive biomarkers, precision risk assessment through pH phenotyping and enhanced image prognostics similarly. And then hopefully the kind of big pie in the sky part of all of this, I think, is to improve the precision of therapeutics. Can we predict response? Can we say that this subphenotype of pulmonary hypertension will respond to this therapy? Obviously, all of this would need to be further informed and supported by randomized trials. I kind of flew through that slide, but that's kind of my next 5 to 10 to 15 years in a nutshell. I'd like to thank my mentors, Dr. Ambal, Carlo, and Rakesh Patel. Rakesh Patel is the one that got me into research. I probably would not be pursuing any of this without him, in addition to my other mentors. And there's my family. And with that, I will conclude and leave a little time for questions if anybody has any.
Wow, Sam, thank you very much. That was an awesome overview of a disease or an entity where we just getting our head around, and you already did like almost a decade of research into it. So it's really helpful for us to tell us about, how you thought about the definition of BPD and the definition of pulmonary hypertension, that there are various types, which comes back later into the treatment. You gave us lots of data of how you come with models to predict, which were related, maybe not necessarily to treatment, but particularly to screening. And what I read is, or listened to, was that late screening was the most effective, but I have some questions about that later. And then you went to this highly detailed analysis of the presentation just at the bedside, which I thought was awesome. Looking at those saturations, the histograms, the hypoxic events, and how you can already look at that particular type at the bedside by just putting some time into the detail of each particular patient. And then you for the path forward, you suggested some trials or even interventions or checking interventions based on whether or not there was a PDA, mechanical ventilation, which both of them maybe can be modulated, or looking with AI at different which patients is which have first the diagnosis, then the treatment is the way we're going in medicine. We're moving away from randomized trials, and I think that's a good thing because we just need to diagnose things first. So awesome overview. Thank you very much. There's certainly some questions in the chat box. Amir had one which was about the validity and which one was the most important in ultrasound, but then you answered his question already. Dr. Yape has the questions about, is there a difference between SGA and not SGA in this particular aspects in development of pulmonary hypertension?
Yeah, there have been a great question. There have been a number of studies that have reported this SGA phenomenon, and I don't know, I can't speak articulately about this beyond like growth restriction and likely informing vascular growth. But I do think about that in the terms of subphenotypes, because some of these babies likely have early fetal programming elements informing pulmonary hypertension, whereas some of these probably have some sort of postnatal injury. Maybe they had normal pulmonary vasculature at birth and then endured some sort of postnatal insult. So I've always thought that the growth-restricted baby would likely have a more severe subphenotype. I haven't had a large enough cohort to sort of represent trajectories in the growth-restricted babies as compared to a choreo-exposed versus a PDA flow-induced versus. But that's to me certainly a big part and extension of this work is a larger multi-center cohort that we can really get a sense of trajectory by these subphenotypes.
And you mentioned that if you do screening early, that 1 month sort of scan, that actually you'd miss a lot. So I guess they develop a little bit later, but maybe that's also related to the interventions or modulation of the effects. How early can we start with treatments to try and modulate it? What's your idea about that?
Yeah, so I didn't have a slide on this, but I have one on the timing of diagnosis and the severity of disease. And babies that have an earlier diagnosis, so actually before 36 weeks, more commonly have a more severe phenotype. And what's interesting is if you diagnose it earlier than 36 weeks, you oftentimes will intervene earlier. And so maybe if you hadn't intervened earlier, they would have an even more a higher frequency of mortality. But I don't know what centers on this call do for babies with that first echocardiographic screening that's positive, because we've certainly had infants that have this new diagnosis for pulmonary hypertension. We reach out to cardiology or whomever manages these patients, oftentimes in conjunction with pulmonary, and they won't oftentimes suggest sildenafil out of the gate. Sometimes they want another echo. They want to sort of see the natural history of these infants play out before they expose the infant to pharmacological intervention for which there's no real evidence. Sometimes they'll suggest or will implement higher SAT targets for these infants. But I think identifying these infants early and the right thing to do for these infants upon finding them early is a really important and unanswered question to me.
Then there's a couple of questions, of course, about the PDA, one of those modulating factors. One is, and you mentioned it a little bit, between 1 and 2 months, but maybe you can be more specific. What will be the optimal timing to do so? And the second question related to that, look, we just had a talk here about paracetamol affecting, pulmonary vasculature growth in a negative way, and you might say the same from ibuprofen from the trial. So, one, when to optimal close it, then two, how to do it.
Yeah, great questions. And I always, whenever I answer that first question, I always do a lot of careful hand waving of this is observational. I don't have robust clinical data or randomized trial data to really support anything that I say. But I will answer the question. I won't dodge it. I think it's somewhere in the 6 weeks area, at least what I do clinically, and it's with one of those more recent kind of analyses that we did by ventilator exposure. I used to be pretty therapeutically abstention-ish around the baby that's off a vent. But now that I'm starting to think a little bit differently about that, if they've got a hemodynamically significant duct on non-invasive support and they're at 6 weeks or something, I'm more inclined to intervene. But we're lucky in that the pivotal trial, which is doing a piccolo closure between, I always get the days wrong, but it's somewhere between 3 weeks and 65 days it'll be one of the first PDA closure trials that looks at pulmonary hypertension. That's one of their outcomes they're reporting, and it's across, I think, 20 sites. But I would say they're probably 2 years away from reporting their data. But until then, I think that's kind of my guess, as good as yours. But I think that will be at least some evidence we can hold in our hands as to the time of when, because it doesn't seem like we should do it early in the first at least 72 hours to a week. That seems like the wrong window, but how long do we allow a duct to overcirculate the vasculature? And then in terms of the how, I guess I sort of answered it with I think device closure at that time point, because pharmacologic closure will probably not be efficacious that later on. But I think that's an interesting question you bring up, is that is how not only how the duct informs pulmonary vascular development, but how the treatment itself impacts vascular development, which is kind of a separate question.
Yeah, and we're learning more and more about it. So I agree with you that probably we're going to need to do more catheter closures in selected patients. Now,
Right.
on the pulmonary hypertension in the, say, with and without the PDA, say at 2 weeks of age, do you think it's all post-capillary pulmonary hypertension, or is it variable?
Yeah, I don't know if we can ever, or not ever, but commonly know with specificity the location of the pulmonary hypertension. Just in that, I think that, or at least early on, I mean, sometimes I think later on that it can be more definitively identified, but I haven't seen that systematically reported either in the literature or really in my echo report. So it's, I think, oftentimes tough to know the precise location of the disease.
Yeah,
But
no,
I would,
I agree. The reporting of left atrium pressure estimates is still lacking in this information and in this data, but I bet it will follow in the next decades as well. Hey, you
but
mentioned.
it certainly informs the therapy, because I've had some infants with pulmonary vein stenosis in which I've started nitric on, and they get floridly overcirculated just because there's that post-capillary bottleneck. And so I mean, I think the location is, critical to understand if you're able to.
Um, I have one more question, which you mentioned BNP as a biomarker. Can you tell a little bit more about that? How do you get to that idea? Does it work? Is it better than ANP?
Yeah, so where I was at UAB before, we would systematically trend those in infants starting at postnatal day 28 till discharge weekly. We get a week, like a Monday BNP. There's a recent meta-analysis on it, and its sensitivity specificity is okay. In clinical practice, I've found some utility. I think when it's just sort of grossly out of range, that's unexpectedly so, it can be helpful. But I would say it's I can't recall on more than one hand how many patients that the BNP has been dramatically helpful for identifying, for screening. I think for babies with established disease, it can be helpful, particularly as you're starting a therapy and trying to measure response, and you're not wanting to get an echo every 3 days or whatever, and the patient's too unstable to cath. I think it can be a helpful parallel data. It's in some selected patients. I don't know if I believe in doing it indiscriminately, but I think selectively in established disease, I think it's helpful.
Okay, it is 1 o'clock. Thank everybody for attending. Thanks, Sam, for your talk and staying up late. This was an awesome overview, and I hope next year when you have some new data, we would love to have you talk again. Thanks so much, everybody. We will be back, I think, next week on some renal.